Hello, welcome to today's Morbidity and Mortality Review webinar sponsored by the Southeastern National TB Center. I am Stephanie Nixon, Training Coordinator at SNTC. Before we start today's event, I have a few housekeeping items to go over. Today's event is scheduled for 1.5 hours, including the question and answer period at the end of the presentation. To verify your participation in this event, please provide your email in the email pod, which is on the screen within Adobe Connect. If you provide us with your email address, we will send you an email with a link to the online evaluation following today's presentation. If you're watching the event as a group, provide us with one email and you can forward the email to the rest of your group. Please be aware that you must complete the online evaluation by 5 p.m. Eastern Standard Time on Tuesday, June 30th if you want to receive nursing or physician credit. If you submit an evaluation, you should receive your certificate within 8 weeks. If you do not receive your certificate, please check your junk or spam folder. You may submit questions for the speakers at any time during the presentation by typing your question in the Q&A pod. Thank you for joining SNTC today. Now I'll turn this over to today's moderator and co-presenter, Dr. Dave Ashkin.
Stephanie, thank you so much. Hey, it's a lot of fun. I'm like looking at all the chatting and what's going on. This is really cool. I wonder if 20 years ago when they were putting all this together, did they ever think that we'd be using this technology to get together in the afternoon to talk about some TV? So really cool stuff. I'm so happy to have you all together, and we have 2 cases to discuss. Just like Stephanie said, if you have any questions, we'll be monitoring the chat. Also, in between, I may open it up and ask you guys to comment, and at that time, if you just push *7, that will unmute you. And please, I'd love to hear from you guys if you have any questions, or *6 to put yourself back on mute. So today we have 2 cases. Unfortunately, I hate to say this, both were mortalities, and they were both complex cases. I think there's a lot to learn, and I'd really like to get started. So with that, what I'd really like to do is I'd like to present, and I'd like to introduce Megan Ninneman. Megan is our physician assistant down at Jackson Memorial Hospital. We're really so happy to have Megan. And Megan, why don't you start the cases if that's okay? We have a lot to go over today.
Okay. Hi, Dave. Can you hear me?
I can hear you.
Perfect. So the first case we're going to start off with today is a 45-year-old African-American female who was admitted to a Miami hospital on May 11th of 2014. At that time, she was complaining of a 2-month history of nausea, vomiting, stating she could not keep food down. She also had abdominal pain with distension, and she had lost about 150 pounds over the last year. She gave a history of gastric bypass in April 2007 with a revision in April 2013. She also gave a history of a DVT to the left lower extremity 3 months prior and had been maintaining on warfarin. She denied any alcohol, illicit drugs, or tobacco use. Next slide. She was followed by her primary care provider previously, who did a CT of her abdomen and pelvis in April 2013. It showed that she had cholelithiasis, ascites, and a possible dermoid mass on the right ovary. The patient was advised to be admitted to the hospital for further workup, but she did not comply.
So this is just for a second. This is an x-ray, interestingly enough, that she had in March. I guess at this time when she was being seen by her private physician, she was starting to have some symptoms. And I think as we all can see here, she has this very large left pleural effusion. The way we can pretty much say it's an effusion is by the meniscus sign. It's almost like water on the side of your glass as it tracks up. You can also see, you really don't see the diaphragm at all, and you really don't see the heart. So there may also be an infiltrate behind it, but definitely an effusion. And on lateral, normally as you come down the spine, it should be getting darker and darker. But as you come down here, you can see it actually gets whiter, and that's again the effusion, the fluid. And you can only see one diaphragm here, and that's because the left diaphragm is being obscured by the fluid. So you only see the right diaphragm here. So she definitely had this left large pleural effusion. And on CAT scan, as Megan was pointing out, she had this ovarian mass here with stranding. And when they see this stranding, it's usually a fatty indication, which is suggestive that there may be a dermoid cyst. And as you remember, dermoid cysts are actually cysts that have different parts of our epidermis, meaning like hair, fat, so that's the hint that it may be a dermoid. You can see here, though, one of the most interesting findings, and we'll be talking a lot about this today, but notice this. This is the spleen right here. And you see how white it is? This is the liver. The liver should be the exact same density as the spleen, but you can see here, it clearly is not. It's darker, meaning that actually it has a different density. It's actually less dense than the spleen, which makes you start to think about that this may be a fatty liver, and a very, very fatty liver, because it's so large and it's much, much darker or less dense than the spleen. So, Megan, what happened?
So she was, as we said before, she was admitted to the Miami hospital on May 11th of 2014.
And this is the CAT scans that they showed that we got from the Miami hospital. And you can see this is the gallbladder here, and she has this thickened gallbladder right here. She also, again, has that density difference. Look here, this is the spleen here, and you can see how dark the liver is, again suggesting that this is a fatty liver, a very diffuse, large, fatty liver. And the other thing that they're seeing here is this is ascites, right in the middle here in the lower abdomen pelvis is ascites. So she has fluid in her belly too. And then the last thing you can see is, again, this mass here. There's actually a difference in density here, again, suggesting that this may be a dermoid. And then lastly, you can see here, this is actually the bowel wall. And you can see this is a segment of bowel that's actually filled with fluid, and the wall is thickened. So she had a couple different abnormal findings, Megan, huh? So what was the official reading there?
So just like you said, Dave, they saw the cholelithiasis, that small bowel wall thickening with inflammation, the fatty liver with the increased amount of ascites, and bilateral pleural effusions, and again, that right ovary dermoid mass. They also found on her labs that she was anemic. Although her liver studies were within normal limits, they were very concerned about that elevated CA-125 of 416, concerning for a possible ovarian cancer.
Right, exactly. And what happened then?
So she developed this low-grade temperature. They did a chest x-ray. There was a question whether there was a left lower lobe infiltrate versus a bilateral pleural effusions with atelectic changes, which they did confirm by chest CT, and then also the chest CT revealed a left axillary lymphadenopathy.
So this is the x-ray here, and I think we'd agree. I mean, it's looking like it's gotten worse. Now bilateral pleural effusion, you can't see the diaphragm again, so there may be something here like an infiltrate, and again, you can't see the left costophrenic angle, again suggesting bilateral pleural effusions. And you can even see the air bronchogram here that suggests there's either atelectasis behind there or an infiltrate. This is the CAT scan here, which again shows the bilateral pleural effusions. Here's the fluid here, and she also has, as we were discussing, atelectasis right here. So that's why we were seeing the air bronchogram. And then, interestingly enough, when we reviewed it, and I don't know if you guys can see this, but there's a very, very tiny nodule right there. And obviously you can't see if I keep sticking the pointer over that. Sorry about that. And as importantly, or as interestingly, she had a huge left lymph node there in the left axilla. So you can really see that was quite big. So what happened there, Megan? What went on next?
So, well, they decided at that time that the patient would undergo a cholecystectomy, hysterectomy, and salpingo-oophorectomy, as well as a resection of that left axillary lymph node. And what they found on pathology was that pretty much everything was consistent with caseating granulomas, no signs or evidence of malignancy, and that the left axillary lymph node, they found purulent material, which was AFB negative, but subsequently culture positive for TB, and the MICs were reported as pan-susceptible. And probably more importantly for her at that time, they were able to rule out ovarian cancer, as both of those ovaries came back with caseating granulomas and no evidence of malignancy.
Yeah, interestingly enough, they found, as we talked about, some evidence of gray hair in the ovary, again, suggestive of the dermoid. But I think you'd agree, it really, really, really kind of, I think, surprised them that she had disseminated TB. throughout the abdominal and peritoneal area, something I don't think they were suspecting at all. And again, just as an aside, remember she had a very, very high CA125, and I know in this country you don't see too much TB of the abdomen, but in countries like India and Pakistan, where they see more TB, you know, that is one of the findings, or at least in patients who have abdominal TB, is that the CA125 will be elevated. So kind of interesting. So what happened then?
Well, they collected sputums on her. Everything was smear and culture negative. She was quantiferon positive and HIV negative.
Again, I think going along with the diagnosis of at least disseminated TB, but really no evidence, at least in the lungs. It looks like those pleural effusions probably are more likely to have been related to the processes going on in her abdomen.
So they went ahead and started her on 4 drugs on May 23rd and discharged her to do DOT at home 3 days later. She was able to complete 8 weeks of PZA, and which was continued or discontinued after 8 weeks, and continued on INH and rifampin twice a week.
So this is a chest X-ray now, and this is on June. This is on sorry about that. This is on June 6th, so about a month after she starts therapy, a little less. And you can see those pleural effusions have clearly gotten better. Now you can see the diaphragm. Now you can see the heart. And she still has blunting of the left costophrenic angle, and she also has blunting of the right costophrenic angle. But again, I think you'd agree, it looks for the most part better.
So she showed up in clinic in August, middle of August, for routine labs. You can see here that her albumin is kind of on the low side, 2.3. Her bilirubin was within normal limits. Her AST, ALT are mildly elevated, but she's not complaining of any symptoms at that time.
All right.
Unfortunately, the patient became non-adherent in August. They had to file an emergency hold order. The patient was then found in November, and she was restarted on court-ordered DOT. And for the most part, she was adherent to her therapy.
This is her X-ray when they found her in November, and now you really can see a remarkable improvement. I mean, now you can see the right costophrenic angle, you can see the left costophrenic angle. You can clearly see here that the diaphragm, I mean, and now you can see the vessels through the heart, what we want to see. So you can really see she's had a really nice response.
So prior to restarting her on meds, on November 14th, they repeated her labs, and you can see here that the total bilirubin now is twice what it was in August, but she has no evidence of transaminitis. So they went ahead and started her back on 3 drugs on November 17th. She was seen again in clinic on December 5th. She said that she was feeling much better. She had gained weight. She wasn't complaining of any other symptoms. At that time, she was switched to twice-weekly therapy with INH and rifampin, and they were able to repeat her labs, which showed that her bilirubin at least was maintaining or maybe slightly lower than it was previously, and her AST and ALT remained within the normal limits.
You know, for 1 second here, I just want to make a comment, and I think you'd agree, Megan, that one of the things that keeps striking me is how low her albumin is. And on the other hand, her AST and ALT are relatively normal. And looking at her liver, looking at that albumin, you'd really be concerned that she was having problems with her liver function. And I think that's kind of what the comments I'd like to make. You know, we always call the AST and ALT liver function tests, but they're really not. They really have no indication of how well the liver is functioning. And for those kind of things, as we'll talk about in a little while, you want to look at things that the liver produces, things like albumin, you know, proteins like that are involved in coagulation. So we follow the PT, PTT, things like glucose, you know. So, you know, one of the things, you know, that I think is important to talk about is when we talk about LFTs, they're really not AST or ALTs. Those are usually more like a transaminitis involved in cellular injury like in hepatitis. But one of the things that would really bother you, I think you'd agree, is that it looks like here that her albumin is very, very low, and the question is why.
Yeah, I would agree with that comment, especially because she seems to be gaining weight. You would expecting her albumin to also be going up.
Yeah, definitely.
So the patient was seen again a month later in January. Again, she continues to gain weight and feeling good, but her labs, repeat labs this time, show an elevated bilirubin of 2.9. And meanwhile, like you said, Dave, the liver enzymes are remaining within normal.
And interestingly enough, if you see here, her alk-phos, which is a sign of her biliary tree, is actually normal, but her LFTs, now I did it, her transaminases, AST and ALT, are normal, but what's very concerning is the total bilirubin now has remarkably gone up. And again, her albumin is continuing to go down, which is very, very concerning. So I guess, at this point, where was she, Megan, in her treatment?
So she had gotten 20 out of the 26 weeks of therapy that she needed. She had been culture negative since July 16th, including a repeat sputum culture in November prior to restarting her meds. So at this point, we need to ask what would we do next?
Yeah, I agree. So let's put out our first question here, and these are always fun. So again, there's not necessarily any right answer. I do mean that. But what would you do? What would you do now? Would you continue meds or repeat the LFTs in 1 week? Maybe hold the meds and do an ultrasound of the right upper quadrant and maybe some serologies to make sure she's not hepatitis positive, for viral hepatitis like A, B, or C. Switch to rifabutin for rifampin and follow the LFTs, or stop the INH rifampin and start her on what we call a liver-sparing regimen, like ethambutol, levaquin, and streptomycin. What do you guys think? So, what you can see here right now, for the most part, first of all, thanks, guys, for doing it. These are more meant for discussions than everything else. We really appreciate it. So, if you look here just, real quick, and while we're looking, you see the vast majority of people would continue meds and repeat LFTs. And I have to say that, I don't think that's necessarily wrong. My only concern would be, and I think just when I'm making these kind of decisions, is I'm thinking about things like where we are in treatment. And that's why we kind of asked that, because I think you'd agree early on when the person's sick and they're still having positive smears and cultures, you may want to continue the person on meds, maybe meds that don't affect the liver, like ethambutol, fluoroquinolones, and streptomycin. But now she's 20 weeks into therapy. She is culture negative. I think I understand also, maybe the idea of like holding the meds and doing an ultrasound, because there's not the same pressure. And one of the things we'll talk about is sometimes the worst thing you could do is continue the meds while the liver enzymes are elevated, mainly because it is, it can really, the whole idea of drug-induced liver damage is that your best chance of recovery is if you pick it up and stop it early. So I think these are the kind of things that you need to look at, is where you are in therapy and what are the risks. And the other thing I have to be honest with you, Megan, and I wonder how you feel, is that, my biggest concern actually is when the total bilirubin goes up. We see a lot of patients who AST and ALT go up, and they do fine, they stop the meds, but when the total bilirubin is going up, that's what really concerns me. I think some of the worst cases we've seen, Megan, together are those cases where the total bilirubin is going up. Do you agree?
Yeah, no, I totally agree.
Yeah, that's kind of called Hy's Law. Like Hy's Law always talks about when you have an elevated, bilirubin in patients who get TB med or any kind of drug-induced, that's the one we really worry about. So let's see what happened. So what happened, Megan?
So, unfortunately, the provider was not notified of the abnormal lab value, and the patient was continued on the medication.
And, just a quick thing. I think all of us have been in that situation, why it's so important, in our clinics, in our offices, that, having a system that when something comes back abnormal, that it gets back to the provider. And, all of us know that sometimes, unfortunately, things fall through the cracks. And, I think we all appreciate that it happens, but it can definitely have sometimes untoward effects. So what happened next, Megan?
So she was then admitted on January 23rd to a Miami hospital. She at that time had a 2-day history of fever, nausea, vomiting, anorexia, diarrhea, weakness, abdominal pain, and increased girth. And
this is a chest x-ray now, and again, I think you'd agree that her x-ray looks not bad. Looks okay. It's an AP film, that's why her heart looks a little bigger. But you can see her diaphragms, everything looks good over here. But what's happening in her labs, though?
Yeah, so on admission, you can see that her total bilirubin continues to go up. Her albumin's about the same. Interesting, her CA-125 has now come down quite dramatically from 416 to 84, but she has that kind of disturbing CEA, which is elevated at 13.1, although the alpha-fetoprotein is within the normal limits. You can also see she continues with anemia. Her platelets are borderline low. She has an elevated PT. So going back to those liver function tests, that's one thing you can also look at. Her alcohol level was 10, and normal is less than 10, so I'm not too sure what to make of that. As a sidebar, she had started taking some kind of herbal tonic, a triple S iron supplement that did have a small amount of alcohol, so I don't know if that was contributing. And then you can see her Tylenol level was 15, so she obviously had ingested Tylenol at some point in time. How much time had lapsed between her taking the Tylenol and this test, or how much, we don't know. But at that time they did check her hepatitis virologies, which were negative.
I mean, very, very interesting. A couple of statements, if I may. First of all, I think you agree the total bilirubin keeps going up, despite the AST and ALT being normal. And that's why one of the things I really would emphasize to you guys, I know the recommendations are to follow AST in patients with TB, but I think many of us also follow the total bilirubin with the understanding that there's two components, and that they don't always go up together, that you can get what we call a cholestatic picture, a picture consistent with either disease in the biliary tract or of the liver, and also rifampin can cause this, versus a hepatitis, a transaminitis, where the AST and ALT go up. And again, like I stated before, though this is a rarer picture with an elevation in total bilirubin, it's more concerning. The albumin continues to go down. We had a great question before. Greg, how's it going? It's good seeing you, hearing you on the conference here. Greg asked before, and I agree, can you use a CA-125 to monitor the progress of patients who have abdominal TB? And the answer is yes. And we do, and you can see in a case like this that as we treat it, the CA-125 actually goes down. The only problem is that if it starts going up, you really can't just say it's a failure of TB. You got to make sure there wasn't an underlying other process. But the answer is yes, Greg. Thanks for asking that question. And then, what I want to show you is the other thing is that the haptoglobin is going down. Again, another protein made by the liver, suggesting that this person is having synthetic function problems. The other thing is that the PT is going up, and I want to make a statement about that. Remember, she did have in the past a history of pulmonary emboli, and had been on warfarin, but it was not on this time. And then, as Megan said, a couple things that bothered her. Her ethanol level was not 0; it was 10, and that bothered her. Was she drinking? At that time, she didn't. She said she denied it. The other thing is her Tylenol level is a little high, and as Megan said, you really can't just take a spot Tylenol. It really depends when she ingested it compared to where she is. So she had taken it, and then what Megan said, which is very interesting, is that she was taking this herbal tea. And as we'll talk about, remember that one of the things that we saw was a fatty liver. And we'll talk about fatty livers, but one of the things that can cause fatty livers is herbal teas. So it's one of the drugs that are associated with it. So it was very interesting. Otherwise, the serologies are negative. So kind of an interesting pattern here. So Megan, what happened now?
So because of this cholestasis picture, they did an MRI with the MRCP, which again confirmed the severe fatty liver disease with evidence of anasarca, but did show any signs of stones or obstructions, masses. So basically there was no evidence for this cholestasis picture. They also did a paracentesis at that time, which was consistent with the transudate, and all the cultures that they did at that time for bacteria, fungus, and AFB were all negative.
So again, I want to show you this is the MRI done of her abdomen. And again, this huge difference in density. And Mark Lobato is one of my favorite people in the world. Mark is on the call, and Mark is asking, like, it looks like a rifampin-related adverse event. That was definitely what we were thinking about when you see a pure cholestatic. The only thing that bothered me with this, and Mark, if you want to comment, just do a *7. It's always fun to hear you. But the question comes down to is that that you shouldn't get this fatty liver. Remember, she had this fatty liver prior to being on the rifampin, or the drug. But it's kind of weird, but I do agree with you, that it's elevated. And the other thing is, the question of that the alpha is so normal, which is also a little bizarre when it comes to rifampin. So what happened, Megan? What did we do? Actually, everybody's asking what kind of herbal tea. So, I just want to say that I really think the reason is, it's about 1:30 here on the East Coast. You guys on the West Coast a little earlier, but it is about that time that, we have our afternoon tea. So, Megan, what kind of tea was it?
It was, it had some kind of an iron supplement with alcohol in it.
Right, actually, Megan, I remember when you had it, you actually sent us the label and stuff. It was never a tea that I had ever heard about, or a supplement that I had ever heard about. It was I don't know where she picked it up. It wasn't a common one, if I'm correct.
Yeah, she started going to an herbal spa at some point in time, which was concerning. I think she was concerned about some of the weight that she was gaining, as she had the history of the gastric bypass. So I think she had started going to this herbal spa, and they had given her some herbs, and we don't know everything that she was given, unfortunately.
Right, exactly. But somebody, Jan is asking, if the alkaline is normal, does that mean it's cholestatic? And I agree, it's probably not. It's probably more directly the liver itself that's actually releasing it. So what happened then, Megan? She got transferred to Jackson, huh?
Yeah, she was transferred here to Jackson for further management and consideration of liver transplant here at our transplant institute.
So what did she look like?
So on admission, she was hypothermic. Otherwise, her other vital signs were within the normal range. She was not in any acute distress. She had very poor hygiene. She had a newly placed central line, also noted to have fine rails to the left posterior lung base. Her abdomen was severely distended with hypoactive bowel sounds. She had 3+ bilateral lower extremity edema. She had multiple skin wounds. And overall, the patient was a poor historian, but cooperative and able to follow simple commands.
So this is never good when your slide is mainly all red values when you're looking at it. So real quick, Megan, what do you see?
So these were her labs from admission. You can see that she's coagulopathic. She has a slightly elevated creatinine. The albumin's still hanging around 2. Her total bilirubin at this point is 13.5, despite being off of all medications. The direct bilirubin was 12. And then you can see that she has an ammonia level of 230, and her platelets now have dropped from the previous level of 134 down to 27,000. And you can see also she has a little bit of hypothyroid, and the ceruloplasmin was low, which we'll talk about in a little while, and the anti-smooth muscle antibody was elevated.
Yeah, so real quickly, I think we would all agree she's in liver failure. She is not producing, her ammonia is high, and she's coagulopathic, and the question is why. And Mark is saying, and I agree, that it looks like it's chronic and acute, and I totally agree with him. I think we're looking at somebody who's had some sort of liver issue that obviously was made worse, The interesting part here real quickly is, the ceruloplasmin, in part of the workup here, you're always thinking about the possibility of Wilson's disease, and hers was low, so it is possible, and it's definitely in the range. So you don't usually get a fatty liver with Wilson's disease, and again, her anti-smooth muscle antibody was high, which suggests an autoimmune hepatitis, but again, not a typical picture with a fatty liver. Things are just not making total sense. Here's her chest X-ray, and again, you don't see the diaphragm. There's this white density. I don't see the left schizophrenic angle. So again, I think that there may be an infiltrate there with bilateral pleural effusions. And Megan, what's going on?
So unfortunately, within 3 hours of arriving in our unit, she became hypothermic and hypotensive. We had to give her IV fluids and start her on empiric antibiotics, and she was transferred within a couple hours to the ICU, where they had to start her immediately on pressors. So the following day in the ICU, the patient was noted to become increasingly lethargic, responsive to painful stimuli only. She developed respiratory failure requiring intubation. and also they thought, given this overall picture, they thought that she was probably in septic shock due to either an intra-abdominal infection or pneumonia. Her WBC had shot up to 21,000. Again, those chest x-ray showed opacities. ID was consulted. They recommended to continue her on empiric antibiotics. She was given lactulose and rifaximin for the hepatic encephalopathy.
Sorry about that.
Slide.
Okay.
They did request a hepatology consult for her acute liver failure. She was given vitamin K for her coagulopathy, along with fresh frozen plasma as needed for bleeding. They had her on Synthroid for the hypothyroidism and IV fluids for developing this acute kidney injury. So the chest x-ray follow-up on February 11th basically showed that the opacity and the bilateral pleural effusions were improving, but otherwise no significant change.
And this is the x-ray here. And again, now you can see the diaphragm through the heart. So again, they thought the left lower lobe, infiltrate may be getting better, but she still has bilateral pleural effusions. And this is just a comparison real quick. I mean, here you didn't see the diaphragm, here you can. And actually, to be honest with you, I'm not even so sure this is really diaphragm. I think this is a subpulmonic effusion. Doesn't matter, you can at least see through it. So the infiltrate got better, but she still has bilateral pleural effusions. So Megan, a hepatology consult, huh?
So hepatology saw her. They didn't think that she was a candidate for liver biopsy given the severity of her illness. They did recommend getting a copper level to rule out Wilson's disease, which they did, and it turned out that it was low and not consistent with Wilson's disease. Then they also recommended getting an ultrasound and doing a paracentesis, but otherwise continuing the supportive care.
So just for a second, when you talk about Budd-Chiari, and we're going to talk about it in a second, but just for everybody else, I think, but what Budd-Chiari is in patients usually who are in a hypercoagulable state. They actually get a clot in their venous outflow from the liver, and it actually can cause an obstruction, and you can get a cirrhosis and failure. Matter of fact, it can be quite bad. And the reason I'm just bringing it up here, everybody always thinks Budd-Chiari, of metabolic hypercoagulable disease. They also think about some of the parasites and in other parts of our world. But TB, which is a hypercoagulable state, which we'll talk about later, can also cause Budd-Chiari. So it's something to always be thinking about. Obviously, you want to do an ultrasound with a Doppler to see what the flow is. So what happened there, Megan? What did they get?
So they found that the patient obviously had medical renal disease, and again, confirming the fatty liver infiltration with ascites, but they found no evidence of a posthepatic venous obstruction to suggest that Budd-Chiari was causing this.
All right. So this is actually the MRI of her lower spine, and I just want to show you that, as Megan had pointed out, this patient, unfortunately, was quite sick, and when she came in, she had a sacral ulcer. This is the ulcer actually coming through that's actually getting to the rectum. So they actually thought there may be a fistula between the sacral ulcer and the rectum. Also, what they could see is massive ascites. Her belly is just now filled with fluid. And then she, again, has the thickened small bowel here throughout. You can see the thickened wall. And so what was the official reading there, Megan?
So again, the radiologist stated that she had a large amount of free fluid in her abdomen. She had that sacral ulcer suggestive of a fistula formation, the diffuse small bowel thickening, and then some atelectasis and consolidation, again, with these bilateral small pleural effusions, and that one solitary right pulmonary nodule.
So we went ahead and tapped her, right, because of all that fluid, make sure she didn't have a subacute bacterial peritonitis. What did they find?
They found that, this confirmed that she had a transudate and not an exudate, suggestive or not suggestive of an infection.
And her labs?
So they did the follow-up labs on February 12th. Again, her creatinine, it continues to go up at this point, now 1.4. Albumin still hanging around the same level. Her bilirubin continues to go up, is now 14.7. AST is mildly elevated at this time, but nothing significant. And her ammonia, again, is elevated at 283 despite the use of lactulose and rifaxiamine. Her white blood count, despite empiric antibiotics, remains high, and her platelets continue to drop.
What's going on with her cultures?
So the culture work, pretty much everything was negative. C. diff was negative, and her blood cultures were negative to date. But they did find that on a bronchial aspirate, she had a heavy growth of yeast, and that was collected on February 10th.
What happened now?
February 13th, she had 5 to 6 rounds of non-sustained VTAC. They had to transfuse her platelets and FFP. She had a Udall catheter placed for continuous dialysis to try to remove some of the fluid from the body and the abdomen, but the problem that they were having was that she was still hypotensive, so they're trying to find a balance between removing some of the fluid without making her hypotension worse. They tried to do a brain CT, but they were unable to do it because as they were trying to move the patient, she would become unstable. But they were, at some point during that day, able to discontinue the propofol and the levofed. So the follow-up hepatology note basically, again, confirmed multi-organ system failure. The main thing to point out is that they also thought that this presentation was not consistent with a drug-induced liver injury due to the TB treatment, but everything else that they had ordered had basically come back negative.
Sorry about that.
Unfortunately, on February 14th, patient developed some facial twitching. They thought that she may be having a seizure, but they were unable to do the EEG because of the patient's wig, which was tightly glued to her scalp. They started her empirically on Keppra for seizure prophylaxis, as well as restarting her on the propofol drip. The patient still remained responsive to painful stimuli. And again, that bronchial aspirate, which had grown a yeast on February 10th on ID, then recommended starting her on micamine as the treatment.
Yeah, I mean, I think you agree. At this point, it's just becoming a point where they're just doing, they know she's really, really immunosuppressed from her condition, just trying to cover everything. Mm-hmm. So what happened now?
So they were finally able to get the brain CT on February 15th, showed which is worrisome for the cerebral edema, unfortunately.
And this is the ultimate, what you're really worried about when it comes to, hepatic failure, is cerebral edema. As you can see here, you can hardly see any sulci. You see that the ventricles are now being compressed. I mean, she has diffuse cerebral edema. Just another, view of it, and you can see that you really are not seeing the typical, sulci and gyrae. I mean, it's all being compressed. All from, diffuse cerebral edema, all probably related to the, the hepatic encephalopathy. So what happened next?
So the patient's overall condition was unchanged, except for now she was no longer responsive to painful stimuli. She was continued on the current course of treatment. Her bilirubin still continues to go up, now 15.3. And her lactic acid and white blood cell count are consistent with a septic picture, and but otherwise her ammonia has come down nicely from 283 now to 88.
I mean, on the other hand, that could be just that the liver is really giving out. I think you'd agree, just not even able to produce. And last thing is, like you said, the lactic acid is really just really showing inability to continue perfusion peripherally. Again, it's elevated, not horrible, but you're right. It could either be sepsis or from shunting now from the hepatocellular failure. So what happened now? What was her lab? They don't look like they're getting better, huh?
So 5 days later, the patient was severely coagulopathic with a APTT now 170. Her bilirubin was pretty much stabilized at that point at 15.6. Her AST now more elevated than previously. Also, the ALP was starting to go up, and her white blood cell count maintained at 22,000, remaining anemic, but her platelet count continues to drop.
And again, I just want to point out the AST is out of proportion to the ALT. And whenever you see that, you think about certain things that could do that. And, in our normal practice, one of the most common reasons we see is that somebody's drinking alcohol. But the other things you worry about is things like muscle breakdown, which I suspect was happening with her, and also like hemolysis. But, again, I'm not so sure the AST was really out of proportion because of liver reasons. I think there was probably something else going on, though you are starting to see that the alk-phos is starting to go up, but again, not horribly significant.
So because of this, on February 21st, palliative care was consulted. Everyone agreed that despite aggressive treatment, that the patient's condition continued to decline and that her prognosis was grave without any chance of meaningful medical recovery. They spoke with the patient's healthcare proxy, who agreed with the primary care team to withdraw life support, and the patient expired that afternoon, and the family received an autopsy.
So I guess, and this is where I'd like to, so, from our perspective, we thought that this was probably, if we're looking at the causes of death and related conditions, that it may have been a non-alcoholic steatohepatitis with hepatic failure, which we'll go through. And, the question was, why did she have it? And remember, she did have a history of morbid obesity, and that's why she had the gastric bypass in the first place. She also had evidence of metabolic syndrome, though was really never a diabetic. But, and then the question is, as I think Mark was pointing out, and I agree, could this have been exacerbated by the TB meds? Then obviously, I think that, ultimately what did her in was, obviously with the liver failure came cerebral edema, and, she may have had sepsis, and obviously underlying it all was disseminated TB, and I think we'd all agree. A question that, whenever you see TB, disseminated TB is why? And I think she was immunosuppressed right from the beginning. To have disseminated TB, especially of the abdomen, and diffusely like she did, she had of the abdomen, the lymph nodes, everywhere they looked, she had caseating granulomas. You really think that she must have been immunosuppressed somewhat right from the beginning, which I think was related to her liver disease. So I guess for a second, what I'd like to do is ask any comments. I mean, I think one of the comments that I saw before that I really agree with is the whole concept that sometimes we do forget that the herbal products are not necessarily harmless, and again, I don't think it really had much to do with this case, but it's one of my, pet peeves actually, that a lot of our TB patients that will see somebody will develop a hepatitis, and we ask them, "Are you taking any meds?" They say, no drugs, no drugs, and then you find out they've been taking a herbal products, especially among many of our patients who come from parts of the world where herbal products are a very commonly used medicinal agent. So I do agree, and I think it's something we always have to remember to ask. Though I don't think it really played a major part, I think it's a great point to stop and ask. So Elizabeth, thank you very much for that. Before we go forward, if you wouldn't mind, I'd really like to hear, Mark, I may put you on the spot if you're on the phone, but *7. So Mark, do you agree, disagree? What do you think?
No, I totally agree, David. I think that her obesity, and we don't know whether she had diabetes at all, but that can certainly lead to fatty liver, and we don't know her long-term course without the TB, but I think she was already heading towards the road of liver failure eventually. So,
Mark, I totally agree, and that's why, any other thanks, first of all, Mark, thank you,
sure.
Always. Any other comments or questions? And then I'd like to do a brief overview, and then we'll go, but, I think, many of us see patients with fatty liver, but I don't think we totally appreciate the full spectrum, so that's what I'd like to go over. But before we do, anything you think that should have been done differently? I mean, I guess the biggest question I have, and, if I had to have a comment, would be, the whole idea that when the patient's liver enzymes were elevated, I do think personally that it should have been stopped or at least switched. But I would have probably just stopped just because of the timing. Mark, while you're on, or anybody else, your comments on that? Like, what do you normally would do, Mark, if you, and I'm catching you off guard here, I'm sorry. And if I was you, this is a good time if you don't want to answer that, your phone goes dead. But
I'm used to it.
What do you do, like, if somebody like this with the total bilirubin being up and they're otherwise fine? What do you think how you would handle it?
No, I agree that early on, definitely she should have had her meds stopped, and I think it's different approaches, but I would have done more extensive workup at that time. I think that the combination of Ionage, rifampin, perhaps her herbal drugs with Tylenol and alcohol, all that may just have an accumulative effect and tipped her over. So was it preventable? I think that's what you're ultimately asking, if there was something we could have done to prevent this ultimate outcome. And it's hard to say, but it would have been nice to have her off the drugs, at least the hepatotoxic drugs, while we were sorting all this out.
Yeah, I agree. I mean, and on the other hand, as sad as it is, I think we'd all agree, the reality is sometimes these kind of things happen, and I think the stress is, one of the things to stress is the importance of getting results that are abnormal back to the clinician as soon as possible. Hey, a couple things real quick. Greg, again, I know has asked, which is a great question, which is, when you're looking at the bilirubin being elevated, what was the, how do you look at the bilirubin and what's the significance, especially direct versus indirect? And in this case, and in most cases where there's direct damage to the liver, what you'll see is an elevated direct bilirubin, mainly direct. And again, that usually shows you a pretty much more of a direct insult to the liver. But from time to time, you'll see an elevated total bilirubin, and the indirect will be much, much higher than the direct. And the most common scenario for that, especially in TB patients, is actually a condition called Gilbert's disease. And Gilbert's disease is just a problem. It's an inherited problem of conjugating bilirubin. It's absolutely benign. And it is quite common in certain populations. I know in the Caucasian population. And interestingly enough, the way you test for it is you give 900 milligrams of rifampin to somebody, and their bilirubin will go up, and it's mainly indirect. As a matter of fact, it's almost all indirect. And interestingly enough, then, in most TB patients, then we are testing for bilirubin for Gilbert's disease in an indirect way. But that's one of the most common, scenarios you'll see an indirect being elevated. But the key there is the patient is totally asymptomatic. All the transaminases are normal. The PT is normal. Albumin is normal. Everything else is well. But they just have this elevated indirect, If you look at, on the other side, one of the most common reasons why you have an elevated indirect in a patient who is not doing so well, it's usually hemolysis. And again, that's because the hemoglobin as it's being broken down is the indirect, it will bind and become indirect bilirubin. And again, you'll see that, but in those cases, normally you'll see a drop in the in the hematocrit, and that becomes key, and there's usually something else going on. And then lastly, obviously, you see it in patients with really bad, sometimes, myoglobin, where you're getting like a rhabdomyolysis. But you are right, and Greg, I totally agree, and we've discussed this before, that when you do have somebody with an elevated total bilirubin, it's very, very helpful to do a direct and an indirect to get an idea where it's coming from. You're totally right. Thanks for the question, Greg. As always, you can also please unmute at *7 if you like. Let's quickly, if it's okay, talk about fatty liver real quickly. And, let's be honest, something we see quite often in fatty liver or steatosis is just simple fatty liver. And again, it's usually caused, the most common is too much alcohol. But other reasons is obesity, insulin resistance, and alteration in triglyceride metabolism. But when you look at drugs, the drugs that cause it mainly are ethanol, steroids, and highly active antiretroviral therapy, in particular AZT and other drugs that affect the mitochondria, And the key here is, though, that usually the liver is functioning fine. It's something you'll see on ultrasound, something you'll see on CT, but the liver is otherwise fine, And almost when it is caused by drugs, it's usually reversible. If you stop it, it gets better. But here's the thing. If you continue to have injury in these cases, as Mark was pointing out, these patients may progress to a hepatitis. Notice the difference. This is no longer just steatosis. This is no longer just fat in the liver. Now the liver is becoming inflamed. There's evidence of inflammation. There's cellular involvement. And these patients are getting sick, and they're at an increased risk of cirrhosis. And if you look at non-alcoholic steatohepatitis, this is actually now being more and more recognized. As a matter of fact, it was first really recognized by our colleagues up in the Mayo Clinic, and they were the first to really start describing cases of patients who were developing cirrhosis without any real clear, etiology, normal etiology, no hepatitis C, no alcohol, no autoimmune. And again, it was mainly seen in patients who were alcoholic, but it also could be seen in patients with diabetes, obesity, metabolic syndrome. And when it's not associated with alcohol, it's called NASH, or non-alcoholic steatohepatitis, and it's a progressive form of the benign steatosis. The key to these is these cases can progress to cirrhosis. As a matter of fact, in the Western world, it is thought to be the, outside of alcohol and hepatitis C, it is one of the leading, it's the third most common cause of cirrhosis outside of those two agents. So we're seeing it more and more, especially in our patients who are having problems with the metabolic syndrome. And obviously, as the metabolic syndrome is becoming more and more common in the United States, we're seeing more of this. And as we think that what this is just a progression of the steatosis with inflammation. And it's the chronic inflammation with the reactive oxygen species that actually causes the inflammation and